Hello friends, greeting from my side. I know you all are waiting for videos on MCQs since long time, and many of you have personally messaged me to help you guys in medicine MCQs. So here I have come up with the general medicine MCQs. Today we will go through a few MCQs on infectious diseases. I'm sure these MCQs will be useful to guide your preparation for NEET super specialty critical care medicine exams. So this is question number one. A 50-year-old man, a known hypertensive, is admitted to the intensive care unit for treatment of septic shock for an uncertain cause. He was suffering from myalgias and fever since past few days. He also had decreased oral intake and generalized malaise. Upon arrival of emergency medical services, his initial blood pressure was 65 over 40 mm of mercury with a heart rate of 142 beats per minute. He was tachypneic with a respiratory rate of 32 with an oxygen saturation of 75% on room air, and his initial temperature was 105 degree Fahrenheit. He was intubated and placed on mechanical ventilation. This patient received 1 liter of normal saline before arrival in the emergency department but continues to have hypotension, blood pressure 75 over 40. Ongoing volume resuscitation is ordered and a patient is initiated on noradrenaline to maintain adequate blood pressure. He takes amlodipine 10 mg daily and atorvastatin 20 mg daily. His only other history is an automobile accident at the age of 20 years requiring exploratory laparotomy and splenectomy. Blood, sputum and urine cultures are obtained. What are the most appropriate empiric antibiotics for the treatment of this patient? Now the options are A. Ceftriaxone and vancomycin, B. Ceftriaxone, ampicillin and vancomycin, C. Ceftriaxone, vancomycin and amphotericin B, D. Clindamycin, gentamicin and vancomycin, or E. Clindamycin and quinine. First of all, quickly look at which system is involved. Looks like here there is a desaturation and tachypnea, probably pneumonia may be the possibility. With post-splenectomy status, you might consider that this patient has about 60 times higher risk for overwhelming bacterial sepsis than the normal population. The most common organisms causing severe sepsis in asplenic patients or post-splenectomy patients are encapsulated bacteria, especially the Streptococcus pneumoniae, Neisseria meningitidis and Haemophilus influenzae. Streptococcus pneumoniae causes 50% to 70% of severe sepsis in asplenic patients. The major long-term complication of splenectomy is OPSI, also known as post-splenectomy sepsis syndrome, which is defined as generalized non-specific flu-like syndromes followed by rapid deterioration to full-blown septic shock within 24 to 48 hours of onset. So in this patient also it occurred. Within hours, nausea, vomiting, headache, confusion, shock and coma can occur in this situation, and the nature of this syndrome makes it difficult to diagnose early enough for therapy to be effective. And ceftriaxone and vancomycin would be the appropriate choice for this patient. So this is the answer. Now let's move on to question number 2. A 32-year-old woman is admitted to the hospital complaining of right thigh pain. She is treated empirically with oxacillin intravenously for a cellulitis. The admitting physician notes that the degree of pain appears to be disproportionate to the amount of overlying cellulitis. Over the course of the next 24 hours, the patient develops profound septic shock complicated by hypotension, acute renal failure, and evidence of disseminated intravascular coagulation. A CT scan of her right leg demonstrates a collection of fluid with gas in a deep fascia of her right leg. Emergent surgical evacuation is planned. What changes to the patient's antibiotic therapy would be recommended? Now the options are A. Continue oxacillin and add clindamycin, B. Continue oxacillin and add clindamycin and gentamicin, or C. Discontinue oxacillin and add clindamycin, vancomycin and gentamicin, D. Discontinue oxacillin and add piperacillin, tazobactam and vancomycin, or E. Discontinue oxacillin and add vancomycin and gentamicin. This patient appears to be having the signs of necrotizing fasciitis because the degree of pain appears to be disproportionate to the amount of underlying cellulitis, and on CT scan of right leg, collection of fluid with gas in the deep fascia is present, which is quite suggestive of necrotizing fasciitis. It is most commonly caused by group A streptococci and a mixed facultative anaerobic flora. And nowadays MRSA cases are flourishing in community, and that is the reason you should cover MRSA in this patient. The risk factor of MRSA include diabetes mellitus, IV drug use, and peripheral vascular diseases. So you must look for these risk factors in a patient. The mortality rate for necrotizing fasciitis is between 15% to 35%, but it can increase to 70% if there is a shock syndrome. The initial antibiotics should cover the typical organisms and include vancomycin 1 gram IV BD, clindamycin 600 mg IV TDS, and gentamicin 5 mg per kg per day intravenously. So these three antibiotics should remember whenever you look at necrotizing fasciitis patient. And because this is a medical emergency, if you don't act fast, patient may succumb to death. As I said, in shock, this mortality can go up to 70%. So the correct option in this patient is that is continue oxacillin because it will not cover MRSA, and change to vanco. And for the anaerobic cover, give clinda, and for gram negative, give gentamicin. Now we'll move on to question number 3. A 39-year-old woman received a liver transplant 2 years ago and is maintained on prednisone 5 mg and cyclosporine 8 mg per kg per day. She has had 2 episodes of rejection since transplant, as well as an episode of CMV and Nocardia pneumonia. She intends to go for a family trip to Adman Nicobar Islands and seeks your advice regarding her health while abroad. Which of the following potential interventions is strictly contraindicated? The choices are A. Malaria prophylaxis, B. meningococcal vaccine, C. rabies vaccine, or D. oral typhoid vaccine. So this question is about the vaccination and the prophylaxis, and which is the contract. And remember that live attenuated viruses are generally contraindicated as vaccines for immunocompromised host for the fear of vaccine-induced disease, because this patient is a post-liver transplant and is on intense immunosuppression. That is the reason we have to be very careful not to give live attenuated viruses based vaccines. So in this example, I would say that you should avoid all these vaccines which are live attenuated vaccine: measles, mumps, rubella, oral influenza, oral typhoid, varicella, shingles, BCG, and yellow fever. Now we'll move on to question number 4. A 19-year-old woman comes to your office after being bitten by a bat on the ear while camping in a primitive shelter. She is unable to produce a vaccination record. On physical examination, she is febrile and appears well. There are 2 small punctures mark on the pin of her left ear. What is an appropriate vaccination strategy in this context? A. Intravenous ribavirin. B. No vaccination. C. Rabies immunoglobulin. D. Rabies inactivated virus vaccines, or E. Rabies inactive virus vaccine plus immunoglobulins. So which should be the answer? So in recent year, remember that rabies virus is transmitted by bats in many countries like China and America. A bite is a clear indication for the most effective immunization strategy involving both active inactivated virus vaccine and passive, that is human rabies immunoglobulin. So you have to give both unless the offending bat is captured and found to be rabies negative with further testing, and which is very difficult task. So better to give these two in combination. So answer to this question is E. Rabies inactivated virus vaccine plus immunoglobulin. Now we move on to question number 5. Which of the following is the most common cause of native valve infective endocarditis in the community? A. coagulase negative staphylococci, B. coagulase positive staphylococci, C. enterococci, D. fastidious gram negative bacilli, or E. non-enterococcal streptococci. So, native valve endocarditis was defined as endocarditis involving native heart valves and not the prosthetic valve or implanted endovascular devices. Community-acquired native valve endocarditis remains an important clinical problem, particularly in elderly patients. And in such patients, streptococci, especially the viridans species, are the most common organism, accounting for about 40% of cases of community-acquired native valve endocarditis. The correct option here is E, non-enterococcal streptococci, the most common cause of native valve infective endocarditis is the community. And also remember that Staph aureus is the most common organism in nosocomial IE or intravenous drug abuse or prosthetic valve endocarditis greater than 12 months old. But in case of prosthetic valve endocarditis less than 12 months old, coagulase negative staphylococcus is the most common organism. So these two important points you should remember. These are the facts, and we have to remember facts, right? Let's move on to question number 6. All of the following are minor criteria and the Duke's criteria for the clinical diagnosis of infective endocarditis except A. Immunologic phenomena, that is glomerulonephritis, osseous node or spots. B. New valvular regurgitation on transthoracic echocardiogram. C. Predisposing condition, heart condition, intravenous drug abuse. D. Temperature more than 38 degrees Celsius. E. Vascular phenomena, arterial emboli, septic pulmonary emboli, Janeway regions, and so on. So remember the Duke's criteria. Sometimes question may be asked, what are the major criteria? There are three major criteria. The blood culture positive for typical organism like Staph aureus, enterococcus, and echocardiography showing valvular regurgitation. These two are the major criteria. Then there are few minor criteria like predisposing cardiac lesion, IV drug use, temperature 38 degrees Celsius or more, embolic phenomena, immunologic phenomena. So if there are two major criteria and one major or two major criteria, or one major and three minor criteria, or five minor criteria, then you can make a definite diagnosis of endocarditis. But if only one major plus one minor or three minor criteria are present, then possibly you can say that there is a infective endocarditis. So this is possible IE. Okay, so in this question, answer is on echocardiogram, new valvular regurgitation is basically a major criteria, not a minor criteria. So let's move on to question number 7. Which of the following patients should receive antibiotic prophylaxis to prevent infective endocarditis? A young woman with known mitral valve prolapse undergoing a gingival surgery. B. A young woman who had an atrial septal defect completely corrected 22 years ago who is undergoing elective cystoscopy for painless hematuria. C. A young man with a history of intravenous drug use and prior endocarditis undergoing operative drainage of a prostatic abscess. D. An old man who received a prosthetic mitral valve 5 years ago undergoing routine dental cleaning. Or E. An old woman who received a prosthetic aortic valve 2 years ago undergoing screening colonoscopy. Current recommendations advise prophylactic antibiotics only for those at highest risk for severe morbidity or mortality from endocarditis undergoing manipulation of gingival tissues or periapical region of the teeth, or second is the perforation of the oral mucosa or a procedure on an infected site. So these three are the high-risk surgeries for which you require the prophylaxis. Remember that prophylaxis is not advised for routine gastrointestinal or genitourinary procedures. High-risk patients including those with prior endocarditis, prosthetic heart valves, unrepaired cyanotic congenital heart disease lesions, or the recently or incompletely repaired congenital heart lesions, valvopathy after cardiac transplant. These are the high-risk patients for infective endocarditis for which you require prophylaxis according to current consensus. The guidelines recommend 2 grams of amoxicillin given orally as a single dose 30 to 60 minutes before the procedure as the drug of choice for infective endocarditis prophylaxis. If the patient has allergy to penicillin, then you may consider clindamycin in the dose of 600 mg oral or IV 30 to 60 minutes pre-procedure as a single dose only. So in this question, gingival surgery is a high-risk procedure, but patient is a mitral valve prolapse, so it doesn't require prophylaxis, so only one risk factor is present. But if you look at option C, here there are 2 risk factors present, intravenous drug use and prior endocarditis. So this is the high risk patient, and the surgery, he is undergoing surgery, the operative drainage of a prostatic abscess, so that is high risk surgery. So the correct answer is C. A young man with a history of intravenous drug use and prior endocarditis undergoing operative drainage of a prostatic abscess. In a patient with bacterial endocarditis, which of the following echocardiographic lesion is most likely to lead to embolization? A. 5 mm mitral valve vegetation, B. 5 mm tricuspid valve vegetation, C. 11 mm aortic valve vegetation, D. 11 mm mitral valve vegetation, or E. 11 mm tricuspid valve vegetation. So remember, although any valvular vegetation can embolize, but vegetations located on mitral valve and vegetations larger than 10 mm are at the greatest risk of embolization. So here the C, D, E all are large enough to increase the risk of embolization, but only choice D demonstrates the risk of both size and location. So 11 mm is the highest size among here all the options, and mitral valve vegetation is the commonest valve which can lead to embolization. So answer is D. So tricuspid lesions leads to pulmonary septic emboli, which are common in injection drug abusers. And mitral and aortic lesions can lead to embolic injections in the skin, spleen, kidneys, meninges, and skeletal systems. So systemic embolization can occur, but the dreadest of all the complication is the neurological complication, which is mycotic aneurysm, focal dilatation of arteries at a point in the arterial wall that have been weakened by the infection in the vasa vasorum, or septic emboli leading to hemorrhage. So this is quite a difficult, quite a dreadful situation of septic endocarditis. A patient is admitted with a fever, malaise and diffuse joint pains. His initial blood cultures reveal MRSA in all culture bottles. He has no arthritis on examination and his renal function is normal. Echocardiogram shows a 5 mm vegetation on the aortic valve. He is initiated on IV vancomycin at 15 mg per kg every 12 hourly. 4 days later, the patient remains sterile and cultures remain positive for MRSA. In addition to a search for embolic foci of infection, which of the following changes would you make to his treatment regimen? A. No change. B. Add gentamicin. C. Add rifampicin. D. Check the vancomycin serum peak and trough levels and consider TID dosing. Or E. Discontinue vancomycin and start daptomycin. So in this patient, there is MRSA and MRSA septicemia, or you can say bacteremia, and echocardiography shows a vegetation on aortic wall. So this is a source of infections, and MRSA is the culprit. And IV vancomycin has been started already in an adequate dosing, but after 4 days still patient is not responding. So the question is about whether to change or whether to add something. So here you have to be careful because still it requires more time. It is too early to judge the treatment adequacy. Okay, patients with an infective endocarditis on antibiotic therapy can be expected to demonstrate clinical improvement within 5 to 7 days, but blood culture may remain positive for 3 to 5 days for Staph aureus treated with beta-lactam antibiotics, and 7 to 9 days with vancomycin. So here we have used vancomycin, so we have to wait at least a week or at least for 9 days. It is too early to the therapy to consider this case representative of vancomycin failure. Okay, so better you wait here, and there is no need to change the antibiotic. So that's all for today. Thank you so much. Like, subscribe, and share this video with all of your friends who are preparing for NEET super specialty critical care medicine. I will come more and more MCQs on infectious disease soon. Thank you so much. Bye bye.